I really appreciate the opportunity to show you some of the work here today. And we're going to talk today about a protein that I spent a long time studying when I was at UCLA, and I started studying it again in a different way here at Children's with a great team that we have there. And there really is a team involved, and I hope to thank everybody at the end. Pediatric epilepsy surgery is heart. The most common etiology that we encounter in pediatric epilepsy surgery, as many of you know, is cortical dysplasia, focal cortical dysplasia. And from a histopathologic standpoint, focal cortical dysplasia is essentially a disorganization of the cortical architecture. So when you look at like an H&E stain of focal cortical dysplasia, these are cortical pyramidal neurons that have lost their way. Their apical dendrites are misoriented. They have bizarre cytomegalic somas. They are very abnormal electrophysiologically as well, and that's something we actually studied at UCLA. But overall, the idea here is that these cells early on in development have lost their way and probably have some aberrations in their growth and development lines. And so in pediatric epilepsy surgery, when dealing with etiologies such as focal cortical dysplasia, even with great surgery, which we try to do 100% of the time, surgery really only works about 50 to 60% of the time. And so one of the problems that we encounter here is, well, what do we do with the other 40 or 50% of children who are not cured with a resective surgery? And if we can only cure 50 to 60% of children with pediatric epilepsy surgery, is this really penultimately a surgical disease? And it's a question that we asked. So my hope today is to demonstrate three things. The first thing is going to be a very basic science share, in which I hope to demonstrate that mTOR is both necessary and sufficient to alter cortical neuronal excitability, the way pyramidal neurons are communicated with and communicate with other pyramidal neurons. And that's really fundamental bench work that I did during my PhD. I hope to use that work to demonstrate to you that there's sufficient groundwork for using an mTOR inhibitor clinically in children. And then finally, I hope to share with you the structure and early findings of a phase 1 clinical trial that we began at Children's about 2 years ago, and what has now become also an open label extension for a couple kids that really had significant changes on the trial, which I hope to share with you as well. And the overarching theme here, hopefully, will be a real bench to bedside endeavor. So we'll start with, how do we take this protein mTOR, and link it to an electrical dysfunction phenotype like epilepsy? mTOR stands for mammalian targeted rapamycin. It exists in every cell in the body. It is a regulator of a variety of cellular processes, and it's integral, and it modulates mainly cellular homeostasis, but a lot of other things too. It's a relatively small protein. It's a serine threonine kinase, and it's been implicated over the last 10 or 15 years in a wide array of neurological diseases, spanning epilepsy and tuberous sclerosis being, I think, the fundamental prototypical disease in which we understand mTOR, how it links to phenotype the best, but also autism, tumors, trauma, and I'm sure a lot of the tumor surgeons that are in the audience today are very familiar with the PI3K, AKT, mTOR pathway. This is what it looks like. Essentially, at the cell surface, receptor tyrosine kinases, they dimerize, and it activates this pathway. And I think the fundamental things to look at this very busy slide is this idea that there's this one protein called P10, which basically can put the brakes on everything in this pathway. There's also the TSC, TSC1, TSC2 complex also puts the brakes on this pathway. But the end effector of this pathway is mTOR, and it forms two different complexes called complex 1 and complex 2. And these are the effector complexes that carry out a wide variety of cellular function, a wide variety of cellular changes, which I'll show you. mTOR complex 1 is mainly responsible for protein translation, ribosomal formation. It changes autophagy. It's involved in metabolism and progression through the cell cycle, which is why in some cases, mTOR dysfunction can lead to an oncologic phenotype, which we don't see in cortical dysplasia, but we do see in other types of tumors. And then mTOR complex 2 is mainly involved in cell survival, but also has a role in actin cytoskeleton dynamics and GABA A receptor trafficking, which is, I think, going to be quite relevant to some of the things that I'm going to talk about in a minute. The prototypical disease, which I think we understand the role of mTOR the best in, is tuberous sclerosis. And one of the great things about tuberous sclerosis is that we were able to recapitulate the phenotype in transgenic animals that have TSC1 or TSC2 knocked out. Now, we all are familiar with TS as a clinical entity: cortical tubers, subependymal nodules, greater than 80% of children having catastrophic refractory epilepsy, and intellectual disability, and of course subependymal giant cell astrocytomas that can present with hydrocephalus and sometimes require surgery. The fundamental molecular disruption that occurs in TS is at that level of TSC1, TSC2. Now, it turns out that not all kids are germline loss of TSC1, TSC2, but a lot of kids are mosaics, meaning that not all cells, not even all neuronal cells, express the loss of TSC1, TSC2, but that it's distributed among cellular populations. But the fundamental principle with the loss of TSC1 and TSC2 is this overactivation of mTOR, which leads to the phenotype of large bizarre cells with bizarre nuclei, resulting in tubers and subependymal nodules, and ultimately the electrical phenotype, which is epilepsy. But due to some really great work that's been done at Children's and elsewhere by my colleagues in genetics, by Jeff Ogeman, Greta Mirza, Bill Dobbins, it turns out that mTOR overactivation is not just restricted to tuberous sclerosis, that instead on this spectrum of cortical dysplasia ranging from hemimegalencephaly, which is essentially a hemispheric cortical dysplasia, all the way to the small focal cortical dysplasias, we see a significant number of these lesions that also show disruptions in the PI3K AKT mTOR pathway, suggesting that these kids are likely mosaic mutations in that pathway, leading again to mTOR overactivation that's somehow related to the overall neurological phenotype. So the overall overarching principles of the original electrophysiologic work, which I'm going to show you first, and we're going to get into the weeds a little bit with some cellular electrophysiology. I hope we don't get too into the weeds. The question being asked was, well, we know mTOR regulates critical cell processes. We know that when it's dysfunctional, it leads to an epiphenotype: epilepsy, tuberous sclerosis, intellectual dysfunction. But how does mTOR, as a abstract three-dimensional protein structure, lead to a neuronal physiologic anomaly? How does it change the way nerve cells communicate at the circuit level? And there were two tools that we had at our disposal. The first is a medicine that's been around for about 30 years, rapamycin. That's an mTOR inhibitor. It binds to and inhibits mTOR all the way downstream at the mTOR level. And that's been FDA approved now for over 30 years, originally for oncologic indications and then subsequently in the transplant population to prevent rejection. The second tool we had at our disposal was a transgenic mouse model. And I know a lot of people here have heard of the Floxed mouse model, so I apologize if I'm reviewing things you've already known. But this is an alpha-cam kinase Cre-driven LOX deletion of P10, okay? And what that means is that these mice in 4 brain pyramidal neurons, so frontal lobe, hippocampus, that's where the alpha-cam kinase comes in, they lose conditionally P10 expression. What that does fundamentally is it recapitulates a tuberous sclerosis type phenotype. So you lose P10, mTOR levels go through the roof, And then histopathologically, they have bizarre large cells. All these animals seize spontaneously. And by about 60 days of life, about half the neurons in the forebrain, hippocampus, frontal lobe, etc., they're affected. They lose P10, they overexpress mTOR, and they have this phenotype. So the way I would think about the P10 conditional deletion is that is our opposite of rapamycin. Rapamycin shuts down mTOR. P10 deletion overactivates mTOR. So I studied electrophysiologically 3 different conditions. We gave normal animals rapamycin, so we shut down mTOR to see what would happen to neuronal communication. We then conditionally deleted P10 in forebrain neurons to overactivate mTOR and see what would happen. And then we tried to rescue that phenotype with rapamycin to see if we could undo any neuronal physiologic anomalies that we appreciated in those models. And this is all done with in vitro slice electrophysiology, patch clamping. So the first thing I hope to show you is that mTOR is both necessary and sufficient for changing cell size and changing what we call the passive electrical properties of neurons. What you see here on the left are what normal neurons look like in a wild type animal in the infrared microscopy. And I kind of drew them out in a black marker. In the conditionally P10 deleted neurons, in which mTOR levels are overactivated, these cells are much larger. And that's what you see there on the right. They're about 50 to 100% larger than the wild type counterparts. When you give these animals rapamycin and you restore mTOR inhibition, the cells get small again. That's what you see here. Not only does it change cell size, but it also changes what we call passive electrical properties of nerve cells. And to think about this, I would think back to your early undergraduate or graduate studies in neuronal physiology and think about things like cell capacitance, which is a reflection of cell surface or cell membrane area. And then things like input resistance, where current input results in a voltage change at the level of the neuron. And what you're seeing here is that rapamycin not only shrinks these cells, but changes their very basic electrical properties. It makes the capacitance smaller and it makes the input resistance higher. And what that means fundamentally is that if you have a cell that's smaller with a higher input resistance, when it gets signals at the dendritic surface that result in current changes at the dendrite, they get amplified. A higher input resistance will result in higher voltage changes at the level of the dendrite that then get transmitted to the soma. And the way I would interpret that from like an epiphenomenon standpoint is that signals get louder when you give cell rapamycin and you drive down mTOR levels. In P10 negative cortex, you have the exact opposite problem. These cells are large, they have a large capacitance and a lower input resistance, which to me means that from a passive standpoint, electrical signals are dampened. After you give them rapamycin, you get a reversal of that phenotype. The cells get small again, which is consistent with what we see histologically when we treat animals that are, for instance, tuberous sclerosis type animals. And again, input resistances go up and those cell signals passively are amplified again. So summation here is that mTOR is both necessary and sufficient for changing cell size at a pyramidal neuron level, but also changing their intrinsic electrical passive properties, changing the way that they conduct current, changing the way they transduce that current to a voltage change. And what that really means to me is that mTOR has a role in both amplifying and dampening signals that come in from the dendrite to the soma. So that's the passive electrical properties standpoint. Well, what about synaptic properties? So what about mTOR could possibly change the inputs, GABAergic or glutamatergic, that nerve cells see at the pyramidal neuron level in the frontal lobe? And the very first experiment that I did when I was getting my PhD was on glutamatergic experiment, and it was a total failure. And like any good PhD student at that point, I was like, oh man, am I ever going to finish this on time? Fortunately, I had some positive experiments with GABA, but of course, the first experiment never works. And so it turns out that mTOR regulation or dysregulation has absolutely no effect, at least on these frontal pyramidal neurons, of glutamatergic neurotransmission. So when we think about epilepsy holistically, what we want to think about is there's got to be an imbalance between excitation and inhibition. So is it in these phenotypes, is it that there's too much excitation, an aberration of glutamatergic transmission, or is there inappropriate or insufficient inhibition? In other words, too little GABAergic neurotransmission. Well, it turns out it's not, that it's glutamatergic hyperexcitation. That doesn't seem to be the case. But instead, there does appear to be a substantial change in inhibition at the pyramidal neuronal level. So what you see here are signals at the somatic surface. These are patch clamp cells that are P10 negative. mTOR levels are high here. And what you see is a significant reduction in their spontaneous inhibitory inputs. From an electrophysiologic standpoint, we refer to these as spontaneous inhibitory postsynaptic currents. So these are current changes that we detect at the soma that are a result of all those little packets of GABA that hit the surface and result in a voltage change, a current change and a voltage change at the cell surface that reflects inhibition. The lower left-hand side graph shows you that the frequency of GABAergic events in these animals with P10 loss are significantly lower, and that spans a variety of GABAergic amplitudes and a variety of inter-GABAergic event intervals. So less GABAergic inhibition in these P10 negative animals. It turns out that this is rescued by the application of rapamycin. So you take these animals that you've now given an mTOR hyper or an uncontrolled or hyper mTOR-like scenario, and you give them rapamycin and you shut mTOR down, you actually restore the inhibition that's lost in the P10 knockouts. So what you see up top is an example recording. The lower left-hand corner is just showing you that you lost inhibition in the P10 knockouts, but then you regain it again when you rescue them with rapamycin. So clearly this is driven by changes in mTOR. And again, it's across a variety of GABAergic amplitudes and a variety of GABAergic inter-event intervals. So whenever we see a change in spontaneous inhibition at the cell surface, the first question we generally ask ourselves is, okay, is this dependent on action potentials or is this independent of action potentials? And the way we figure that out is that we add tetrodotoxin, which blocks action potentials, to see if you still see a change in inhibition. And as it turns out, when you add tetrodotoxin, you still see a reduction in inhibitory postsynaptic currents, meaning that this is non-action potential driven release of GABA that seems to be reduced here. What you see in the upper left-hand corner is an example recording of less inhibitory currents in a P10 knockout. On the upper right-hand side, you see a significant reduction in the frequency of events. And on the lower right-hand side, you see again that this is distributed among a variety of amplitudes and a variety of inter-event intervals, which are what we call miniature GABAergic events. Again, this is rescued by rapamycin, which is really cool because again, it means that it's mTOR dependent. So when you give these P10 knockouts mTOR inhibition, when you restore their mTOR inhibition, all of a sudden you've rescued not only the spontaneous inhibitory activity, but the non-action potential dependent inhibitory activity. The lower left-hand side shows that you have this increase in frequency of miniature events that seems to be quite substantial, and again, distributed among amplitudes and inter-event intervals. Finally, you want to see whether or not you can evoke inhibitory events on these pyramidal neurons by placing an electrode in a different layer of cortex and stimulating it, and seeing if that results in a change of GABAergic neurotransmission at the level of the pyramidal neuron. And it turns out it does. These P10, so when you give rapamycin, it actually changes the way these cells receive evoked inhibitory events. It dampens them. And in the P10 knockouts, you see a substantial change in the way that these evoked events occur. Now, granted, these are not natural events. These are events that we induce in slice, but it's substantially different. And again, it's rescued by the administration of rapamycin. And so that sort of whirlwind of data that I just showed you really, I think, fundamentally comes down to this slide. So I showed you, hopefully, that mTOR not only changes cell size, but the passive electrical properties of nerve cells, but it also changes their synaptic properties. It changes their excitability at the inhibitory level in both cell autonomous and non-cell autonomous manners. And it has to do with GABAergic release. And there's a variety of different explanations for this that would require probably a couple years worth of experiments, but at least we know that the epiphenomenon at the circuit level is directly related to GABAergic neurotransmission. Finally, it not only affects synaptic activity, but it also affects membrane excitability. And that's the intrinsic excitability of a neuron when they're stimulated to evoke action potentials. So what you see here is cells that are treated with rapamycin are more hyperpolarized at rest. That's what this is right here. You actually lower their resting membrane potential with the application of rapamycin. Not only do you lower the resting membrane potential, but it actually changes the way these cells have voltage changes when you give them current. It makes them less excitable, essentially. And it changes the amount of voltage that they need to fire an action potential. So it just slows these neurons down when you inhibit mTOR. In the P10 knockouts, as it turns out, they are hyperexcitable. And again, that hyperexcitability is rescued with rapamycin. It makes these cells quieter, okay? So all of that basic science, electrophysiology, what does it mean? How do we interpret it? How do we bring that to the bedside? Well, the way I would like to think about everything I just showed you is that mTOR clearly has a role in modulating the excitability of pyramidal cortical neurons. And we'd like to hope that that has direct translational implications. There have been some animal studies that have suggested that rapamycin could be an anti-epileptogenic or disease-modifying agent. Rapamycin could also be anti-epileptic, meaning it could stop the seizures as they're occurring. We know it's been used in humans for tuberous sclerosis, which is the only real clinical trials that have been done to date with rapamycin for a neurological phenotype. And people have thought about it, at least through the treatment of other cognitive disorders, but haven't really used it yet. Taking the electrophysiology to the end, there are a lot of different directions that that could go. But I think the fundamental principle that we can draw from this is that mTOR is necessary and sufficient for changes fundamentally at the cellular level that change excitation. These cells that have hyperexcitable mTOR are hyperexcitable themselves. And it's mainly through loss of inhibition, through changes in resting membrane potential, and through changes of passive electrical properties. Which brings us to the second half, which is bringing this to the bedside. And really, I I have to say, I feel like I owe this part of everything to doctors Ellenbogen and Ogeman, who, when I was interviewing for the job at Children's some years ago, sat down with me and said, Jay, you have a PhD, you studied mTOR for years, why don't you just do a clinical trial? And at the time, I just nodded my head and I'm like, oh yeah, that's a great idea, you know, not really knowing how to get it off the ground. But it turns out that it was very possible, and it really was due to the support of the department and Drs. Ellenbogen and Ogeman that really motivated me and our team to get this off the ground and just start figuring out a way to give this to children to see if we could help them with their epilepsy. And that brings us to present. So just starting from the beginning and laying the groundwork for the clinical trial piece of this. Among children in the general population, the incidence of epilepsy is about 5 per 10,000. Of these, approximately a third will be medication resistant. That's 1 or more seizures per month that persist after trying more than 2 anti-epilepsy drugs. And after a child has failed generally 2 AEDs, the chances of additional medications eradicating the epilepsy is less than 5%. And that's based on landmark studies that were done by Ann Berg now over 15 years ago. And it really lays the fundamental groundwork for pediatric epilepsy surgery, why we offer pediatric epilepsy surgery. Intractable epilepsy in children has significant neurodevelopmental sequelae. It leads to intellectual dysfunction. It leads to impairments of cognition, language, social skills, communication. We call that the epilepsy encephalopathy, which looks similar to kids who are on the autism spectrum. Kids with medically intractable epilepsy have lower rates of high school completion, lower rates of employment, of marriage, and of overall socioeconomic success. And of course, there's a mortality risk that's associated with epilepsy, mainly related to SUDEP, which is 0.5 to 1% per year, and it's cumulative, which can get quite substantial in children with many years ahead of them. While surgery is effective in a lot of children, it doesn't cure everyone. So when we evaluate children in an epilepsy conference and we review all the phase 1 data, what we're fundamentally looking for is evidence to push forward a plan for a curative resective plan, meaning that we have a general knowledge of an area, either lesional or non-lesional, that could potentially be resected for cure of epilepsy. And it turns out that on the whole, we do okay, but we don't do phenomenal when it comes to curing all these children. So approximately 40 to 50% of children, even after a well thought out and well executed epilepsy surgical plan, can continue to have seizures. And once epilepsy surgery with an intent to cure fails, the options become quite limited. They get cycled through a multitude of anti-epilepsy drugs, which I just showed you have less than 5% chance of working, or they get considered for palliative surgical approaches like VNS or corpus callosotomy. So what do we do with this substantial portion of kids who have failed epilepsy surgery and really have no other avenues for therapy? Well, hopefully we can lay a little bit of preclinical groundwork, some of which I showed you already in the electrophysiology studies, but there's a bit more out there. It turns out that in animal models of epilepsy, these are not P10 knockouts, so this is not mTOR dependent, but in animal models of epilepsy in which you inject either canic acid or pilocarpine, these are drugs that you inject in an animal and then they spontaneously seize and go into status. Rapamycin actually can change their propensity to enter into status. It actually reduces epilepsy in these general animal models of epilepsy. It also changes the way their hippocampus changes with status epilepticus and reduces muscle fiber sprouting. And in models of TS and P10 conditional deletion, when you pre-treat them with rapamycin, they don't seize. And their EEG normalizes. This is in animal models. The majority of clinical experience that we have with mTOR inhibitors to date is in the TS population. One large non-controlled trial came out of China back in 2014, in which 52 patients with TS and seizures were treated with rapamycin for a total of 24 weeks at 1 milligram per meter squared per day, and they had a 1x to 2x reduction in their daily seizures. It wasn't a great study in that it was uncontrolled, and these children are probably being changed on their anti-epilepsy medications during the study, but at least suggests that there might be a role of mTOR inhibition with regards to epilepsy. Perhaps the greatest mTOR inhibitors in the setting of epilepsy and TS comes from the EXIST trials. These are the original tuberous sclerosis trials that led to a change in the way we treat kids with TS and SAGAs. As many of you know out there who treat SAGAs, the now first line treatment of SAGAs is not surgical unless they have hydrocephalus. It's actually with everolimus, and that's where the EXIST trials came into play. So the first EXIST trials looked at the mTOR inhibitor everolimus with regards to SAGAs. And it showed that it stabilized or reduced the growth of SAGAs in the vast majority of children who were treated. But as a secondary outcome, they found that epilepsy was improved in these kids too. So the third iteration of the EXIST trial was a double-blind, placebo-controlled, high versus low dose everolimus trial looking at epilepsy outcomes. And it turns out that in these kids treated with everolimus, there was a 30 to 40% reduction in seizure frequency that was dose dependent in these TS kids. So we gave them an mTOR inhibitor and their epilepsy frequency reduced substantially. There were also a number of smaller studies that recapitulated the EXIST-3, but the EXIST-3 is the largest study to date. Which brings us to using mTOR inhibitors in a non-TS population, i.e. things like cortical dysplasia. The underlying idea here was that seizures that are refractory to medical and surgical therapy increase the risk of morbidity and mortality in kids with epilepsy. At this point, beyond surgery, options for these kids are quite sparse and suboptimal. And so our hypothesis was, can we use this mTOR inhibitor? In this case, it's a rapamycin analog called ABI-009, which is intravenous, given once a week. Could we give it to these kids and make a difference? There were two underlying hypotheses that we tested. The first, that we are testing actually, the first is that this medication is safe and well tolerated in kids who have medically refractory epilepsy who have failed epilepsy surgery. And second, that if we add ABI-009 to their existing regimen, that we could possibly detect an efficacy signal, that we can improve the control of their epilepsy. And the reason for this, like I said earlier, is that mTOR inhibition in a non-TS population really has not been done before, and there really are no therapies for these kids. These kids are at the end of their road, and there are quite a number of them. This is a phase 1 safety study designed for both safety and tolerability endpoints that are primary, as well as secondary endpoints related to seizure control and quality of life. And the way we enrolled kids into this study were that we needed them to have continued seizures despite being 3 months post-operative from a surgery with the intent to cure. So these kids were all evaluated by our multidisciplinary epilepsy conference and felt to either be no longer candidates for additional resective surgery, or their families no longer wanted to pursue resective surgical options for cure. This is the basic study design. On day 0, kids were screened and enrolled. 30-day seizure diary on their home AED regimen, as well as a behavioral index called the Niesanger Index, a quality of life in children with epilepsy index, and a Columbia suicide rating inventory. And the reason for the suicide inventory had to do with the fact that the FDA specifically wants us to study suicidality and depression in kids with epilepsy. So that was a request of the FDA. We observed them on their home AED regimen for 30 days. And then at 30 days, we put them on drug. And they received nabrapamycin or ABI-009 for a total of 3 doses. That dosing regimen was what the FDA allowed us to do, and I can explain why in a second. And then at the end of that dosing regimen, we evaluate them with regards to safety, AEs, adverse events, tolerability, meaning compliance, and hopefully quality of life and behavioral index outcomes. And then finally, we observe them for an additional 3 months off the experimental medication to see if they have any changes in their epilepsy frequency and quality of life. So the reason why we did 3 doses of ABI-009 had to do with the FDA's request to keep it limited to 3 doses because they had really not experienced any other group trying to use a medication that is a non-traditional anti-epilepsy medication in an epilepsy population. So they have a lot of experience using this in the oncologic world, but when the FDA reviewed our study, it was in the neurology section, not the oncology section that was reviewing it. And they felt like their experience with mTOR inhibitors was pretty limited. And so they really wanted us to start low and slow, which is what we did at their request. The way we did the design of this study is an oncology design in which it's a 3x3 dose finding regimen. So we started with a cohort of 3 children who were at a 5 milligram per meter squared dosing regimen, then a second cohort at 10 and the third at 20. And as long as these kids weren't having any dose limiting toxicities, we would continue to escalate the dose to the 20 milligram per meter squared dose, which is where we're at today. The primary objectives were related to safety and tolerability, looking at dose-limiting toxicities and maximum tolerated dose. We recorded adverse events and documented their severity, recorded the compliance of families, and recorded the number of participants that either voluntarily or non-voluntarily withdrew due to adverse events. Our secondary objectives were related to percent reduction in seizure frequency, median percent reduction, treatment response rate and seizure frequency overall, as well as rapamycin blood level response relationships. So this brings us to progress to date, which is really exciting for us, children's. We've enrolled a total of 9 kids in the study. 8 have completed it entirely, and 1 is now being dosed. He's in progress. We've been able to escalate all the way to the highest dose cohort. And what that means is that we haven't had any significant dose limiting toxicities requiring a reduction in the dosage of nabrapamycin. We've had 100% compliance, meaning that every single child, every single parent has shown up for every dose, has shown up to every study visit. These are phenomenal families. They're very highly motivated because they really don't have any other therapeutic options. Many of them are excited because there really aren't many clinical trials out there right now looking specifically at this population of kids that have failed epilepsy surgery with an intent to cure. The vast majority of kids that have been enrolled have had cortical dysplasia. The most recent child that's enrolled has tuberous sclerosis. We're seeing improvements in seizure frequency that are pretty substantial. We're seeing improvements in seizure-free days. We're seeing this most substantially on the last week of dosing, which is really exciting. And as you would imagine, what we're seeing as well is that the reduction in seizure frequency corresponds to the dosing of the medication. And then once they're off medication for the last 3 months of the study and being observed, their seizure frequency returns back to baseline. Again, supporting perhaps a necessary and sufficient conclusion that mTOR inhibition is related to the change in their epilepsy frequency. But even cooler than that, we're seeing changes in domains that we didn't even think we'd be seeing changes in. Parents are consistently reporting improvements in behavior, improvements in sleep patterns, reduction in aggressive behaviors across multiple subjective domains. And these kids' home AED regimens are not changing, so we don't think it's related to that. it turns out 3 of the kids that were enrolled on the phase 1 in the first cohort, 2 in the second cohort, had such substantial reductions in their seizure frequency that they asked us to continue on drug after the phase 1 trial was over. So we went back to the FDA and we negotiated with them an expanded access plan called an open label extension, in which we're able to keep 3 of these children on drug, originally off study, now on the OLE. So what we did with these 3 kids is that we placed ports, and they're coming in for a 2-week on, 1-week off dosing regimen. So they're getting nabrapamycin for 2 weeks and then off for 1 week. One of the kids that's on the open label extension, she has a known AKT3 mutation, which really again supports the notion of using an mTOR inhibitor in this population. She probably is our most remarkable responder. She had had a hemispherectomy and started seizing from the contralateral hemisphere. She was having up to 100 seizures a day. She's now been seizure-free for over 6 months on an mTOR inhibitor, which is not only a dramatic improvement for her, but really has a substantial impact on her mom, who's taking care of her. And naturally, as a skeptic, I was wondering whether this would be a honeymoon effect, like what you see with other anti-epilepsy drugs that kids are started on, even those that are medically intractable, in which they have a month or 2 of reduction in seizures, followed by a rebound increase in seizures again. But she's now been on drug for more than 5 months, and she continues to be seizure-free, completely seizure-free on nabrapamycin, which is really cool. The other 2 kids that are on OLE have had substantial reductions in their seizures as well. One of them, who is our first to enter the OLE, he also has had substantial behavioral improvements, as reported by both himself and his mom, which has probably kept him on the right track and has actually enabled him to be much more productive as far as getting a job now, holding on to a job, and having a better relationship with his peers, which has been really cool too. We've had 100% compliance on the OLE, and we're really excited to see where that brings us. So in summation, hopefully, having taken you from the bench to the bedside, our plan is to develop a multi-institutional phase 2 trial powered for efficacy. Now, the phase 1 is a safety and tolerability study, and basically because we've had no significant AEs that have resulted in a de-escalation of dose, and we've had 100% compliance, we feel really confident that that can convince the FDA to allow us to proceed with a phase 2. And I should have mentioned that ABI-009 is not a labeled medication, which is why we're starting with early phase trials. Our plan is for it to be multi-institutional. We've been asking ourselves a lot of questions about design lately, as far as duration of dosing, which will probably be a 2-week on, 1-week off design, the way we have the OLE. Having a placebo arm, maybe with a crossover, starting half of the patients with placebo, the other half on therapy, and then washing them out and reversing it, putting one on placebo and the other on therapy. Making sure that we're measuring the right endpoints. Not only should we be looking at efficacy with regard to epilepsy, which I think we all feel pretty confident that is sufficiently powered, we'll see a significant reduction in epilepsy, but making sure that we're also studying some behavioral endpoints with regards to sleep, aggression, quality of life, and making sure that we're including the right patients. And this is something that our team has been discussing quite a bit, whether or not we should only include patients with known AKT, PI3K, mTOR pathway mutations, or whether we should take all comers who have failed epilepsy surgery, since there is at least a suggestion that mTOR inhibition may help all kids with intractable epilepsy, regardless of their underlying etiology. One idea could be to prospectively biopsy these kids after stereo electroencephalography, sequence them and see if there's an mTOR pathway mutation, and then enroll those kids on trial prior to a resective surgery. And then making sure that we have a good biorepository in which we can do deep gene sequencing to detect with a high degree of reliability mutations in this population. I know that was a bit of a whirlwind of basic science clinical trial work. I really have so many people that have helped me with this over the years. The cellular physiology was a team that I worked with at UCLA during my PhD. Many of them are now retired, but several of them are still running cellular physiology labs, both at UCLA and around the world. And that work was supported by some NIH money as well as some local funding at the UCLA level. And perhaps the most thanks I have is for our epilepsy translational team at Children's. There are so many people here who have put in an incredible amount of effort with designing the study, doing all the basic science that's led up to the justification for the study. I also want to give a shout out to Amy Lee and Russ Geyer and Jim Owens and Stephanie Randall, who sit on the DSMB, which is integral to getting the study forward. And again, I want to thank, Doctors Ellenbogen and Ogeman, who've really, I think, motivated me to take this to the next level and have supported me along the way. We have a variety of funding sources. The company AADI that makes ABI 009 is providing funding for the study, but it is an investigator-initiated study, meaning that they didn't design the study. They are not regulating the study. We designed it at Seattle Children's, and we hold the IND, which is really cool. And we have some money from Brotman Beatty and some SCH Foundation money, over $1 million worth of support for this study, which I really appreciate.